Now, without any delay, we'll further heading towards our second session, which is on the novel pain medication. For chairing that session, I'll request Major General Dr. Amjad. He's a professor of anesthesia and pain consultant, certified in pain relief from Pain Research Institute, Liverpool, UK. He's former member of Faculty of Anesthesia at CPSP, and he has previously head the Faculty of Pain Management at CPSP. He's former head of Pain Management Center at CMH Rawalpindi, and for his exceptional services for Pakistan, he's been rewarded Hilal-e-Imtiaz Military in 2017. Please welcome Major General Amjad Iqbal. Our next chairperson is Colonel Dr. Rashid Iqbal. He is Associate Professor in Charge Pain Management at CMH Multan. He is also a supervisor and examiner of Fellowship Program of Pain Medicine. Welcome, sir. Okay, now for our first talk is by Dr. Michael Graham, Serpell. So he's currently practicing as consultant in pain medicine in Scotland, Scotland's largest regional pain center. He was a council member of the British Pain Society from 2006 to 2013. He was the chair of the Research and Scientific Committee of BPS. He was the chairman of Neuropathic Pain. He was also chairman of the Local Arrangements Committee for IASP World Congress on Pain held in Glasgow in 2008. He is a senior series editor of Anesthesia and Intensive Care Medicine since 2002. He was block editor for pain for the RCA e-learning in anesthesia project, which was awarded a gold medal by the UK government. Dr. Michael is an associate editor for the EJP and grant reviewer for several major research charities. Dr. Serpell has published 4 books, many chapters, and over 60 original research papers. He will be talking today about the novel pain medication and whether cannabis is the actual cure or not. Please welcome Dr. Michael Serpell. Welcome, sir.
Well, thank you for that very kind introduction, and thank you to the Society for inviting me out here. I'm very privileged, and I have been overwhelmed by the hospitality shown to me so far, so I am looking forward and I am enjoying this conference. So, as I say, I'm from Glasgow, Scotland, and my remit today was, well, that's my declaration of interests. I can guarantee you I don't have any financial interests in use of cannabinoids. This is the structure of my talk. I'll give a little bit about the history and the background to the background science behind receptors and cannabinoid molecules, but I want to spend most of it on presenting the clinical evidence for its efficacy. So, just to start, that the cannabis plant, which you're all familiar with, Cannabis sativa, the main components of that plant that produce the cannabinoids that we're talking about today are the leaves in the top picture there, and also the flowers. This is a picture of the oil being produced at the germination phase, and it's from these parts of the plant that the cannabinoid molecules are performed. It's known by many different names across the world, listed there. I'm sure you're familiar with vitamin M stands for vitamin marijuana. The two most common forms are the actual dried leaves themselves, usually smoked as marijuana, or the extracted resin known as hashish. And cannabis has been known to humans for at least 3 millennia. It's been found in the body of exhumed mummies from over 1,000 years BC, so it obviously has been used for some purposes in the past. The classic tetrad of symptoms and signs that using cannabis produces are analgesia, also psychotropic effects of being chilled out and relaxed and high, but also reducing of muscle function and decrease in temperature. So for those kind of reasons, it's found its way into being used for painful conditions like rheumatism or anxiety, and as a hypnotic. And the lower diagram shows that it's obviously used as an appetite stimulant or nausea suppressant in resistant chemotherapy type patients, cancer patients, but it's also being used for decreasing muscle spasms in conditions like myotonia and muscle great thing, and muscle spasms from multiple sclerosis. So it's found its way into a lot of therapeutic uses, but we really want to tease out, is it clinically beneficial for pain, which I'll be focusing on. So just a quick resume on the cannabis receptors. Two main types, cannabis 1 type, which is predominantly in the central nervous system, versus cannabis 2 receptors, which are more in the periphery and dealing more with immunosuppression, anti-inflammatory effects, a little bit of analgesia as well. But they're both G protein coupled receptors. The diagram there is showing where cannabis receptors are located within the brain. The sort of sagittal section here, very high concentrations in the dark green areas of the brain, so the globus pallidus and the substantia nigra, but you also have quite high levels in these lesser green areas, the cerebellum and the caudate nucleus and the putamen. So it's in lots of different areas of the brain, and in fact it's the second most common receptor in the brain, second to acetylcholine. So obviously it's there for a reason and has a lot of functioning within the brain. The most powerful agonist for this CB1 receptor is THC, or delta-9 tetracannabinol, which is I'll be talking about later. The type 2 cannabis receptor, mainly peripheral, and it's CBD, or cannabidiol, which is the main active agonist of that particular receptor. So you've got cannabis 1 and 2 receptors. If you have a receptor in the body, there's got to be a ligand somewhere, and that was discovered in the early 90s, anandamide, which ananda means bliss, and it's a substance breakdown product of cell membranes from arachidonic acid, so it's ubiquitous, it's all around the body. So a plentiful receptor, but a plentiful ligand to be found. There are other endogenous ligands as well, which we don't know what their main role is. The difference between the cannabinoid receptor compared to a lot of others in the neurotransmission pathway is that although the cannabis receptors on the presynaptic nerve, when a nerve stimulus comes down to the nerve, you don't have little vesicles of endogenous cannabinoid to be released. The actual cannabis is produced in the postsynaptic cell. So after stimulation, presynaptically, it's synthesized very, very quickly and transported to the presynaptic receptor, where it activates the cannabinoid receptor. The cannabinoid is then very quickly broken down by FAR, or fatty acid amide hydroxylase. So this may be some mechanism in the future, I'll speak about at the end, where delaying this breakdown may prolong the effects of endogenous cannabinoids to allow us to get some meaningful clinical activity there. The bottom mechanism, the end result with cannabinoid receptor activation, is a change in these functions within the cell, which leads it to be more hyperpolarized or less likely to be discharged and activated. So it's an inhibition type mechanism. And where this all fits in, it's often linked to the endogenous opioid system that we know very well, and that is a system where opioid receptors, very high concentration in the periacrital gray, are stimulated by usually frontal cortex stimulation, activates the opioid receptors, which turn on this descending inhibitory pathway, which then inhibits the dorsal horn of the spinal cord, where all the afferent painful stimuli are coming in. So we know that's the opioid system. The cannabinoid system is thought to work in a similar way, but it's separate from the opioid system. and it's mediated mainly by cannabinoid 1 receptors. So just briefly about the pharmacology. Cannabinoids are very lipid soluble, and so this results in them being maintained in the body for quite a prolonged time. So if you smoke a cannabis, and outlined in the red line here is the blood level of cannabis, a very rapid peak when you smoke it. It's a very rapid absorption, and it rapidly comes down in a bimodal way. The decrease here is through redistribution into other tissues, predominantly fat-containing tissues, rather than excretion. The slower extraction phase is down to metabolism and excretion. So it retains in the body for a long time. And you can see that in the CNS dysfunction, impairment, effects from a single joint inhaled by pilots and looking at their poor performance in a flight simulator. And this poor performance doesn't normalize till about 48 hours after the ingestion. So the drug lasts a long while. Different ways of taking it. Obviously, smoking is very rapid, has a 50% bioavailability, which is reasonably good, but it has all the problems of smoking cigarettes, carcinogenic. The oral route's much slower, much more variable. And that should be 10% bioavailability, and it's 50% up here, wrong way around. So the oral route is slower and much more variable. To note is the different concentrations of THC in different types of street cannabis. Back in the early 60s, 70s, it was only 1 to 3%. Over the decades, it's become much more potent. So you get much more potent, higher concentrations of THC. And in some of the hashish oils, you can get up to 60, 65%. So the sort of production is to trying to get more and more of the THC component. So that's the basic science component of the talk. The next is, what is the clinical evidence for its efficacy? We know from preclinical studies in animal models, it's actually very effective in a lot of different pain conditions, particularly inflammatory pain and neuropathic pain. So the hope is that it's going to deliver the same results in clinical studies. The problem with human studies is that there's a lot of different factors that make it difficult to distill the clinical evidence. One is the pain model. We've got acute pain, cancer pain, we've just heard. I'll be focusing on non-cancer chronic pain, but you've got different types of pain which may be responsive to a more or less degree. You've got patients in studies are usually highly selected. They're usually medically fit, mentally fit, so they're less likely to have side effects. So any side effects you see in studies are probably an underestimate of what will happen in the real world when we have sicker patients. The actual compound tested, is it just the single ingredient, active ingredient like THC on its own, or is it a blended one with CBD, and what is the ratio? Routes of administration, I've alluded to, difference in bioavailability. Obviously with chronic pain, we're going to be doing multi-dosing to last a chronic time period. In humans, that's 12 weeks. Often need to be done with comparators like active placebos rather than inactive ones to make it truly double-blind. And patients are often on other concomitant medications. Do you take patients off all those drugs or just add on the cannabinoid in the hope that it improves things? So, and measurement outcomes, important to look at pain as the primary outcome. This is just a slide to show that each different color represents a decade in the activity of applications to the US Food and Drug Administration of new drug applications for cannabinoids. So there's been a lot of applications over the past 50 years, over 800, and half of them in the past decade. So there's been an explosion of research and applications for cannabinoids. And in the early stages, it was just available by smoking, and then tablets came. Now, over the past 2 decades, we've got lots of different formulations, from topicals to extracts to botanical extracts to very highly pure ones to synthesized to vapors. So lots of different routes of administration. So there is a lot of work going on, mostly in pain and addiction, but there are these other conditions that the neurologists and psychiatrists are looking at. So a lot of research has been produced, which is great. This is a review paper reviewing the reviews of cannabis, just showing you how many have come up. There was only one in 2001. We've had an explosion of systematic reviews. But if you look at the quality of them, overall, most of them, 70%, are very low quality. They're very critically low in terms of confidence of being genuine. And that's predominantly with the pharmaceutical sponsored type research who have an interest in having good results. If you look at Cochrane, much more selective and critical in what papers they will analyze, you have a better sort of quality of trials and a better confidence. So if Cochrane is the best way to review, let's start with the two reviews they have on cannabis. This one is on chronic neuropathic pain versus placebo, different extractions of the plant, 16 studies, just 1,750 patients. What they found was the benefit in pain, NNT for 50% pain reduction, about 20. NNT of 20, that's the confidence limits. So that compares poorly compared to neuropathic drugs, which amitriptyline maybe 3, gabapentinoids maybe 6, 7. So this is NNT of 20, a lot weaker. If you go for 30% pain improvement, it's a bit better, but still weaker than the other drugs. Side effects, pretty well tolerated. Only 10% of patients withdrew from the trial versus 5% placebo. So NNH, number needed to harm, is quite high, which is what you want. Most of these side effects are subtle and tolerable by the patient, and they mostly involve CNS, like sedation, drowsiness, although there are an incidence of psychology, anxiety type conditions as well. So their conclusion was the potential benefits, we know they're small, may be outweighed by the harms. This is Cochrane looking at cancer pain in particular. Fewer number of studies with patients, and they came out with moderate certainty and low certainty that the various forms of cannabinoids are ineffective for cancer pain. And usually we think, cancer pain's the one area that cannabinoids could help because cancer patients are using them initially for appetite stimulant and antiemetics. But for pain control, actually, the evidence is pointing that it's not helpful. So looking then at the reviews, and this is a more recent review, just wanting to show you where the direction of travel is. In a high impact journal, lots of papers reviewed, but they whittled them down to less than 1%, 18 RCTs, 7 cohort studies. What this review, though, which was different, was separate the different trials into those with high THC ratio to CBD, those with low ratio of THC to CBD, and then those with comparable 1-to-1 ratio. So normally a high one would be more than twice the level of THC versus CBD, but it can be a lot higher. So it's trying to tease out the different balances and ratios of cannabinoids and which might be more effective. And this is their summary slide here, and I've modified it to highlight the differences. That with high THC, it was only the synthetic group versus the plant extract group that did show a reasonable decrease in pain, which is good, but disappointingly, no change in overall function. And we want decreased pain and improved function with pain studies. Whereas the sort of comparable 1-to-1 ratio of THC CBD had a decrease in pain scores, not quite as high as the high THC, but interestingly did show an improvement in function, although it was small. Side effects between the two were very similar. You'd expect maybe THC to have more side effects, but here it doesn't. So this shows you maybe there's a difference between one type of formulation and another, and we should look at that. Another recent review with the BMJ looking at both cancer pain, that's all the results below the red line, and non-cancer pain studies. And they got 28 non-cancer studies for cancer, and the basic results were showing for the non-cancer pain, for example, that yes, you see an improvement in pain in the right direction, but it's below the clinical meaningful level that you would want. So a scale of 1 out of 10, it's less than that. So it's an improvement, but it's very small. And that is the same for function and for sleep. So their conclusions were that you did see a small, very small improvement, but was it clinically appropriate or, worthwhile? I think Canada is the one country that is leading the way in cannabis activity, and they're doing lots of research, and some people say we should change the flag to represent what their research activity more is in keeping with. This is a very recent paper, just the last month or two, looking at real-world evidence of cannabis use, and here they tease out whether it's high THC versus low THC, high CBD and versus equal. And it was a 1-year trial looking at patients over 3 months, and this is a snapshot just to show what they're showing, that they looked at the type of pain as well. High, over 40% of patients had neuropathic, and 40% had nociceptive. And what they found was that the neuropathic pains tended to be more severe, high pain scores, higher dysfunction, and they required higher levels of THC in the mixture that was treated with them. So this is kind of evidence coming out that we should be researching these kind of formulations in these type of pain models. Side effects, very common, 30%, but very low and mild and tolerable. So the short-term adverse effects of cannabinoids are generally tolerated, and they're mild. What we are really worried about, though, is the severe ones. Addiction and abuse and psychiatric problems. This paper put Professor Nutt in a difficult problem. He was showing that cannabis is actually less of a harmful thing, not just to the individual, but to society. Less harmful than tobacco and alcohol. And yet cannabis in the UK at that time had been graded to a lower grade C cannabis control drug, less legal punishments for that. It's now been put back up to 4, which is a higher. And that was where the science and the politics disagreed with each other. I'm just on my last couple slides. So the risk of schizophrenia or acute psychosis, it's well known to be increased with the use of cannabinoids. These reviews suggested a 3-fold increase in the risk of schizophrenia with cannabis use. But cannabis use is only responsible for 14% of the presentations of schizophrenia, so there are other more powerful precipitants. So the risk factors, any cannabis use increases it. If it's regular cannabis use, it goes up. But your genetic factors, whether you've got first or second degree relatives, are much more powerful influence as to whether you'll get schizophrenia. And some metabolic issues, if you've got catechol-O-methyl transferase, VAL, you're more likely. So it may be that, as we did with the opioids, giving guidelines to make opioids prescriptions safer, to reduce harm for patients, we should do the same with cannabinoids, and maybe if we're going to use them, keep on research, but make sure the patient is, mature. The more likely to develop schizophrenia if they're exposed to cannabis in their teens or 20s. Make sure they don't have any family history. Make sure no previous use, and that you could test them pharmacologically for whether they have this amino acid thing. So the future for cannabis research is maybe to try and look at CB1 agonists, but maybe the ones that work peripherally in the spinal cord. Maybe look at CB2, which is also analgesic, but to a lesser degree. Maybe 4 inhibitors might slow the degradation and allow the endogenous cannabinoid receptor system to prolong its activity. So in conclusion, I will just say that cannabis is not a cure. There is evidence that it plays a role in the body and that it does have a weak analgesic effect at best. Side effects are usually tolerable and mild to most degrees. And as Cochrane says, the potential benefits may be outweighed by the harms, but we have to be very careful about that, and we need to control for schizophrenia and make sure the risk to the patient is minimal. Patients are already using it, so we need to get up to speed and deal with it now. And on that note, I'll conclude my talk, and thank you very much for listening.
Thank you so much. Now we'll proceed towards our next speaker. Next speaker is Dr. Gauhar Afshan. She is the Tajdeen Hussain Jafar Endowed Professor of Anesthesia and Pain Medicine at Aga Khan University, Karachi, Pakistan. She is the founder of the multidisciplinary pain setup in Pakistan and former chair, Department of Anesthesiology, and is currently heading section of pain medicine at AKU, Karachi. She is deputy chair of the Pain Management Committee's WFSA, member 2025 Global Task Force IASP, and convener Pain Medicine at CPSP. She has also won many national and international grants and is also involved in several leading multidisciplinary pain research projects. Dr. Gauhar is the author of more than 150 peer-reviewed publications and serves as reviewer and member editorial board of many national and international journals. Please welcome Dr. Gauhar Afshan. Today she will be talking and sharing her new insight into ketamine's role in pain and beyond. Please welcome Dr. Gauhar Afshan.
Thank you very much, Sadaf, and thank you very much, Scientific Committee and Organizing Committee, for this opportunity. So, my title is New Insight into Ketamine's Role in Pain and Beyond. So, I don't have any conflict for this lecture. What I'm trying to do in the next 18 or 20 minutes, that I'll very briefly talk about ketamine and esketamine. Mechanism of action, which is very important because now its role is beyond pain, so we have to see what is its mechanism of action. I will try to share some of the interesting literature related with the ketamine, its analgesic potential and the beyond. I will also talk about how can we explore, especially living in this part of the world and practicing in this part of the world, the new roles of ketamine to use in better way. At the end, I would just share a personal experience about its use in ketamine and beyond, and certainly I would like to then conclude. I know that majority of people sitting here, although they are attending the pain conference, but they have the anesthesia background. So I don't need to see in the detail of this ketamine. We know that the ketamine is a versatile and established anesthetic. It is like we have been using it for more than 50 years in the discipline of anesthesia. Unique quality of ketamine is dissociative anesthesia, in which the patient apparently appears awake but remains unresponsive to the surgical stimuli. Recently, there has been increasing interest or attention towards the use of subanesthetic doses to provide analgesia in a various kind of pain, and we all know about the acute pain and the perioperative pain, but currently more of a chronic pain and the variety of the chronic pain, including the neuropathic, that is a new role. This is a very beautiful, I must say that, picture of ketamine. And currently, the people are talking about ketamine, considering its properties, is an alternative of, so alternative, opioid alternative, considering the side effect of opioids. So the ketamine, the plus point of the ketamine, that it's a potent analgesia when used it properly in a rare indicated patient. It got a minimal intrinsic respiratory depression. So again, this is a very positive effect in if you compare with this gold standard of opioids. It mostly favorable hemodynamics profile, because this is not an issue in majority of the patient, and the side effect which we may have, they are manageable. So these, because of these qualities, it is considered that, especially in the countries like ours where the opioid, we don't have much opioids, and certainly we want to make our patient pain relief, so the ketamine is a good opioid alternative. In our university, we have a research group, and in one of the research group title is the alternative of opioids, and we anesthesiologists, we actually make this group with the pain background, and we are actually looking for a research project where we can make a good alternative of the opioids, because we know the opioid, the government policies and other genuine reasons, we cannot use it in a majority of the cases. So what is the mechanism of action that make it so attractive for many of the indication? So ketamine mechanism, we all know that it is a N-methyl deasparate receptor antagonist. So NMD, and we all know that about its effect. So this, the ketamine blocks the NMD receptors. So and we all know the NMD receptors are involved in the transmission of pain signals and the development of central sensitization. So one of the currently coming emerging effect is that to prevent the central sensitization, using it in the acute pain, and certainly in some of the surgical conditions like mastectomy, thoracotomy, where we anticipate that the patient may develop central sensitization or persistent post-surgical pain, these drugs make wonder. One of the very important mechanism of action of ketamine is the modulation of descending pain pathway, apart from the NMD receptors. That means we know that we have a natural pain control mechanism in our body. So this ketamine, actually, it enhances our natural mechanism, the modulating pain pathway. So it influences the internal mechanism, and in that way, it decreases the pain. Another very important mechanism of action is an inhibition of hyperalgesia and allodynia. And this is hyperalgesia and analgesia by preventing it, because it repeatedly sensitization, it prevents so that the hyperalgesia, either it never develop, it prevents developing the hyperalgesia and allodynia, or if develops, so it may decreases these sensation, the painful sensation. Other than the NMD receptors, the ketamine also, work on the other receptors like opioid receptors, nicotinic and muscarinic receptors. And because of these receptors, they may enhance or complement the pain relief in patients who are having a multimodal pain therapy. And very interesting role that is coming up recently is anti-inflammatory. And how does it come as anti-inflammatory? The people start using it in chronic diseases like pain of the rheumatoid arthritis, pain of the fibromyalgia, and then when they see that they use the ketamine, they find, especially if these chronic inflammatory conditions have acute onset on chronic, then these drugs really work. So now this new anti-inflammatory effect, where they said they actually pro-inflammatory pathways ko enhance karta, it enhances the pro-inflammatory pathways. So this drugs can be used for many inflammatory conditions if appropriately indicated. Only one slide about the S-ketamine. So S-ketamine is a derivative of ketamine, and it also acts on an NMDA receptors. So main function is the same, but the pharmacological difference is basically the onset of pain and their site of prior working. So unlike the ketamine, it is very, very potent and faster acting, and it has shown rapid antidepressant effect as compared to the classical ketamine, although the classical ketamine has also been used in depression nowadays. So it has shown that the rapid antidepressant effect is so rapid that often within hours it making a promising option for a patient who have not responded to traditional antidepressant, and we need something to do something for that patient. Additionally, it is sometimes used in anesthesia as ketamine, and some of the office-based anesthesia. I haven't experienced that, but I was just reading about in some of the office-based anesthesia procedure room. The anesthesiologist, pain physician, they are using S-ketamine for a rapid onset and the rapid recovery. So if you see the science of ketamine, considering is derivative, the phencyclidine derivative, and its proposed proven mechanism, we can see that the ketamine is an NMDA receptor antagonist, it is anti-hyperalgesic, it is opioid sparing and opioid alternative, it is anti-inflammatory, it can be used in psychiatric application and the neuroplasty, which is currently one of the area of concern for after the acute pain. So we all know as anesthesiologists the role of ketamine in acute pain management and perioperative pain control. It plays a very important role in acute pain management and the perioperative pain control, especially if you are making a multimodal analgesia. Its primarily mechanism, as we just discussed about the NMDA receptors, it is particularly useful for managing surgical pain and preventing transition from acute to chronic pain. So the surgical procedure where you anticipate that these patients may develop the persistent post-surgical pain or central sensitization, this drug is very good. And certainly literatures, based on the literature, we can see some of the surgical procedure, they have tendency to develop the central sensitization, so we can use on those patients. Low doses has been shown to prove post-surgical pain control, reduces inflammation, and also enhances the patient recovery. So this is certainly a very unique recommendation because the three association, the American Society of Anesthesiologists, American Society of Regional Anesthesiologists, and American Association of Pain Medicine, the three societies, they made this recommendation of ketamine for perioperative pain control, and they very nicely written clear guidelines that shows what is the recommendation, and they also provide the level of evidence and the dosing regime they also provide. So certainly especially the junior anesthesiologists who are not familiar with these guidelines, they can have that in your operating theater, and then it can be used accordingly. Now coming to another role, which is the ketamine in neuropathic pain. So neuropathic pain, we all know that the dysfunction in the nervous system, and often resulting in chronic, severe pain that is difficult to manage by the traditional or the conventional medicines. Ketamine has emerged as a valuable treatment option for neuropathic pain, particularly in cases where conventional treatment failed. It blocks the NMDA receptors in the central nervous system, and it is the key to its effectiveness in the neuropathic pain way to reduce the anti-hyperalgesia effect. It helps reduce hyperalgesia, commonly associated with common conditions. Its anti-inflammatory properties may contribute in reducing neuropathic pain by modulating the neuroinflammatory pathways. And again, this is important, that how it works. And its common indication of ketamine use in neuropathic pain, that neuropathic pain in the CRPS, or in the post-herpetic neuralgia, in the diabetic neuropathy, phantom limb pain. They are the 3-4 main areas where the people are using it. So what are the dosing regime? I am not going to the detail of this dosing regime. It is available in majority, but there are so many literature available about this, and why I place this one, because I am following this regime. So that's why I'm putting this regime, but there are many other regimes also available. So normally we can start from the low dose regime from 0.1 to 0.5 depending on the time of the presentation, how severe the pain is, and then we can plan a maintenance therapy. And maintenance therapy, main of the cases, and certainly we are actually maintenance therapy by doing the oral ketamine. And oral ketamine certainly may be used for ongoing pain management later on, because these neuropathic pain is not going to settle down in weeks and months. Sometimes it takes years. When you use this ketamine therapy for neuropathic pain, we need monitoring and adjustment, and because this is some potential side effects like dissociation or hallucination, we need to monitor a patient, especially the patient on oral ketamine at home. Then certainly we have to consider all these closely monitoring or follow-ups. Adjustment to dosage and frequency depends on the individual tolerance and response. and it is recommended to initiate treatment in a control setting. Whenever you do first time the ketamine infusion, certainly it has to be in a hospital setup where all kinds of monitoring is available, and it is not without any monitoring, considering the ECG and respiratory rate and pulse and everything, and under control of that you can do the first treatment. Its role in the fibromyalgia and rheumatoid arthritis is very, very interesting. It is coming up not in the anesthesia or pain literature, but in the rheumatology literature they are coming up. And they are using it in chronic in patients who are suffering from the fibromyalgia or rheumatoid arthritis for years and years, and they have been on non-steroidal anti-inflammatory drugs or anti-rheumatoid drugs, and adding this small oral ketamine actually making them comfortable, and they don't require hospital admission, which normally requires 2 or 3 times sometimes, and they don't require the opioids, and the requirement of opioid are less. So this is a very, very potential area of using it in patients who are suffering from chronic pain in fibromyalgia and rheumatoid arthritis. It can be used as opioid alternative because as I told earlier, that our interest is to see the strategies or how we can produce a good pain control without opioid because of shortage of opioids and the very tight opioid or narcotic policies in Pakistan. So it really suits us that if we find anything which is alternative of opioids. Ketamine offers, we believe that this is an alternative and we can be used sensibly. Again, it depends on in which condition you are using and what is like multimodality you are using it. But currently, a lot of granting agency are, giving you the grant money for these clinical trials for low risk dependence or the opioid alternatives. We see a lot of cancer patients, and sometimes the cancer patients also aging, and they, apart from their cancer pain, they also have some other degenerative problems or backache or knee pain, but apart from that. And see that if they are already on so many medication of cancer pain, and if this added pain comes, so again it was seen that in these patients, adding ketamine, a small dose, again 0.25 to 0.3 milligram, small dose, is giving a good quality of life. Psychological benefit, in addition to the physical pain relief properties, ketamine has shown promising results in treating certain mood disorders, which are often associated with any chronic pain conditions to anyone. And this dual effect can be particularly beneficial for patients whose chronic pain is compounded by depression and anxiety. So depression and suicidal ideation, this is again one of the very sensitive area, and ketamine gives robust and rapid relief for major depression and suicidal ideation. The mechanism of this effect, although we don't know, but the proposed mechanism that the major depression disorder is associated with synaptic downregulation in the prefrontal cortex and hippocampus. It is believed that the ketamine causes glutamate surge that leads to the series of events resulting in synaptogenesis and the reversal of the negative effect of the depression, which is a problem in such patients. And this is a landmark paper, the ketamine treatment and the global brain connectivity in the major depression. And since this paper comes, a lot of research is being done, and the people are using it, knowing this safety profile of ketamine. Even the psychiatrists, not in other part, but in America, they have started in their office-based clinics, they have started this kind of a ketamine infusion in refractive and a major depression. In this landmark paper, what we find that the functional magnetic MRI, fMRI study in patients with treatment-resistant depression compared with the healthy volunteers demonstrated that ketamine normalized depression-related prefrontal disconnectivity. So this is a fMRI proven findings that how the ketamine can change the brain connectivity in a major depression patient. Ketamine is particularly effective in treating treatment-resistant depression, as this paper also showed. Unlike the traditional antidepressant, which can take weeks to show, ketamine works within hours. That is, people are talking about, this is the major advantage of this, by modulating the brain glutamate system, especially the NMDA receptors. The ketamine also showed results in anxiety and the post-traumatic stress disorder, and it reduces the symptoms of anxiety and post-traumatic disorder, again by modulating the natural inhibitory pathways for the pain. So, because of the shortage of time, so I will just share a 1-year experience of from the patient from our pain registry. Dr. Leena was talking about the importance of pain registry. Certainly, this is very, very important, and we have a pain registry. So I got this to patient. So one of this patient is Naila Amjad, which is who's a 53-year-old woman who's self-referred, just to see from the website the pain services is there. So she comes with a typical CRPS on the left hand. She had multiple shoulder surgeries in America. 1 surgery, 2 surgery, 3 within a 3 months time, and then she developed CRPS. Then she had multiple stellate ganglion again in America. So she came after a year with this problem, and we discuss in our grand round, because we have a 5 consultant, and we normally discuss in our grand round. But when we started such kind of a patient, and we decided to put this patient on the IV ketamine, and she had, I will just show the result of this. Another patient is a 28-year-old, 28-year-old girl who is having repeated abdominal and pelvic surgeries for pelvic pain, and she again come with the pain with hyperalgesia and altered sensation in the pelvic region. So both of the patients, we had one patient is a compliant, which is patient number 1. The second patient is non-compliant, so we don't have much data, but both have a reasonably good pain relief. So considering all this, I would like to conclude that the ketamine's evolving role in pain management is providing new avenue for relief of patients suffering from acute, chronic, and refractory pain. Its unique mechanism of action targeting NMDA receptors distinguish it from conventional analgesia, making it effective in treating neuropathic pain. Potential benefit of ketamine extend beyond pain management, and emerging research highlights its promising role in treating mood disorders such as depression and PTSD. Further research will likely to uncover even more therapeutic application, reinforcing ketamine's significant impact not only on pain medicine but also in neuropsychiatry and beyond. It is not on analgesia beyond, now neuropsychiatric and beyond. Thank you very much.
Thank you so much, Professor Dr. Gauhar Afshan. Now we'll be moving towards our last talk of this session, a pre-lunch session. So we'll be having Dr. Clare. Dr. Clare has worked as an NHS consultant, and we all know her very well, but for those who have just joined, okay. So she's an NHS consultant in anesthesia and inpatient pain management for over 15 years. During this time, she completed her PhD in social science and medicine on global aspect of pain management. She is a founder member and previous chair of Essential Pain Management Advisory Group at the Faculty of Pain Medicine of the Royal College of Anaesthetists, and previous chair of the Pain Management Committee of WFSA. She has led EPM programs in many low and middle income countries and overseen its rollout in medical school across UK. Since leaving clinical practice in 2022, she has worked as a consultant for the Global Health Partnership Charity, and now she's working as a clinical advisor to NHS on injectable medicine guidelines. She'll be talking about the world's opioid crisis today. Please welcome Dr. Clare.
Thank you very much. Thank you very much, and hello again. This is still where I live. Okay, so what I'm going to talk about now, I've never been told I'm too quiet before. That's a first, but that's good. Okay, so I'm going to talk a little bit about opioid distribution at a global level. I'm going to talk about some of the differences between high and low income regions. I'm just going to briefly outline some of the initiatives from a global perspective on pain management. and then talk a little bit about my research and my findings, and explain how I think it influences how we should be tackling issues around global pain management, and particularly opioids. So, as was actually mentioned this morning there by Dr. Siddiqui, I think, this is the statistic that says that over 5.5 billion people, that's over 80% of the world's population, live without access to treatment for moderate to severe pain. And that's essentially saying people don't have access to strong opioids. To put that another way, of nearly 300 metric tons of morphine equivalent that's distributed a year, just 0.1 of a ton goes to low-income countries. Now, every country has to report their opioid consumption to the International Narcotics Board. This is a very useful website. It's changed over the last few years, but essentially they collate all of this data, and you can look at country-level graphs, look at opioid use for all sorts of different variables. What's a little bit more difficult to do at the moment is to get comparative data. So the graph I've got is a few years old, but it's still representative. So this is looking at opioid consumption per capita. The red line here is the global mean. And there's two important points here. One is the column on the left, so the USA, showing a sort of grossly elevated amount of opioid use, and the other are the very, very small regions. So here we've got Africa and Southeast Asian region of the WHO, and they show obviously very, very low levels of use. So there's two different issues here. The first one I'm going to talk about is overuse, and we've had a lot of publicity from this over the last few years. This is from the BBC, primarily talking about the opioid epidemic of North America and really the USA. These are some figures from the CDC in the USA, pretty shocking statistics showing 130 people dying every day from opioid misuse. That does include illicit opioids as well, but there is a huge problem from opioid prescriptions too. So the other figure there at the top, 11.4 million people misusing opioid prescriptions. These are huge figures, and they've had an enormous amount of publicity. I just want to highlight really the relevant points on overuse. Firstly, just to say that it is quite contested, some of it, and some of it is contested as to whether everything that's happening in North America is going to happen elsewhere. But nonetheless, I'll highlight the main points. So firstly, this point that we've heard a little bit about already this morning, that there's been overzealous prescribing for the treatment of chronic non-cancer pain. And that happened a few decades ago when people mistakenly, in retrospect, thought that we should be treating chronic non-cancer pain the same way as every other pain. But we have since got good evidence, really, that shows that is not the case, and it's only a very small number of people for whom it's effective for chronic non-cancer pain. And in essence, we should be keeping strong opioids for acute pain and pain at the end of life. The other thing that happens in America that we certainly don't see in the UK, and those of you who lived in the UK or worked in the UK will know that we have a very strong system of GPs, general practitioners or family doctors, and everybody has to be registered with one prescriber. So it's very difficult to get multiple prescriptions, which is what will be common with illicit users. But in the United States, it is very easy to do that. People don't have to be registered, so it's much easier to go to many prescribers. And there's also direct marketing to patients in the United States. We don't have that in the UK, and that does make a big difference because people will demand certain things. And this has led over the last few years to a lot of revised guidance. There's been national guidance from the organisations we're all familiar with here, IASP, the body here for which we are the chapter. There's been guidance from the WFSA that I was involved with producing. This is from the UK, from our Faculty of Pain Medicine. It's a good resource. It's freely available to have a look at, called Opioids Aware, also with Public Health England, I think, and some other groups. But again, many messages, but the number one key message here from their website is that opioids are very good analgesics for acute pain and pain at the end of life, but little evidence that they are helpful for long-term pain. So that's the big take-home message. And it's a good resource here if you want to have a look. Not surprisingly, the United States has also produced guidance, so the CDC has also got a lot of information now about trying to improve the prescribing of opioids. And there has been some changes. This is from a Lancet paper. It's using a slightly different metric, but it's showing the same problems. So the top map is from 2015, and the bottom one is from 2019. The red and orangey areas are areas of high use, and the green and blue are areas of low use. And you can see there has been a change in the last few years, but the most notable change is that the usage in the United States has come down. There hasn't been a big increase in the areas of underuse. So underuse is still very much a problem, even if we are making good progress with overuse. So just to talk a little bit about reasons for low levels of use, this is actually well researched. As I'm sure you'll know, there are a lot of problems with education. Often this is called opiophobia. So that is where people become afraid of using opioids even when it's appropriate to use them. So even for acute pain or pain at the end of life, people are frightened of potential side effects. And we all know opioids can be quite tricky to prescribe. It can be difficult to get exactly the right dose, because the right dose that different patients need can be very variable, and the right dose that a single patient may need in different circumstances is also very variable. But also this is compounded by the fact that people often don't use opioids, and so the less you use them, the harder they do come to use. Policy is a big problem, and it's often related to overly stringent legislation. So we all want some legislation to prevent diversion and prevent misuse. But if it's overly bureaucratic, it can be very difficult to overcome, and it's often quite costly. You often need quite a good system in order to be able to have bureaucracy that works, if you know what I mean. So bureaucracy whereby you can still access the medicine. So often that there can be overly bureaucratic systems. And then medication availability. Because there's a lot of bureaucracy to overcome, it can become more expensive to make opioids available. So sometimes the pharmaceutical companies will not put money into making very cheap preparations. So oral morphine that will cost a few pennies, a few rupees, is not available because it's too expensive to make it available. So you can get the converse situation whereby fentanyl patches will be available in pharmacies in some low-income areas, and because they're expensive, they're essentially not available to most users because they can't afford them. But the pharmaceutical companies will put effort behind making them available. So you get a funny situation there. And this has been well described for many years, these problems, and there's a lot of literature around this. So just moving on slightly to some of the initiatives that have been out there from lots of organizations looking at pain management. So these groups, you'll be familiar with most of them, of course, and we've talked about some of them this morning. The first thing I want to say is that all of these groups, and there obviously are others, who've looked at global aspects, they've all got an international bent. So they're called the International Association or the World Federation or the World Health Organization. But actually all of these groups, like many others, are Western-based. They're based in high-income countries. And that does, I think, skew sometimes some of the view, and it privileges a particular worldview on how we discuss things. So I think, although they're doing very good work, it is just worth bearing in mind that sometimes the picture is slightly skewed. The other point I want to make is that the top two organisations, that's IASP and the WFSA, probably the groups that the anaesthetists here are most familiar with, are the groups who tend to have done work looking at all types of pain management, so looking at acute pain, chronic pain, and pain at the end of life. But most of the initiatives that we've seen, particularly looking in low-income areas, are actually really quite small. The really big work that's been undertaken are by the lower organisations here, and the point about that stuff is that they're big studies and they're big advocacy projects, but they've nearly always focused on palliative care and opioid access, which, although that's a very important thing to be doing, it is just worth bearing in mind that it has that skew. So firstly, they're not looking at all types of pain management, all types of pain conditions. And secondly, they're only looking at one type of treatment. So they're missing out on all of the other interventions and management types that we know are so important. So I'll just show you some of them, just to focus on a couple of them. And I won't spend long, but just so that you know about them, they're freely available to download. This is an atlas on the availability of palliative care, and it shows what palliative care is available throughout the world. It's very interesting looking at all different countries and mapping it, and also talks about opioid access, but also gives us an estimate of what the potential need is of palliative care. And this is a similar study, the slide that I showed earlier. This is from the Lancet Commission on Global Access to Palliative Care and Pain Relief. Again, it's a big initiative. It's very well written and very easy to read and free to download. Again, this map, as I showed before, demonstrating that issue around opioid availability. With Northern America there, the country's land size disproportionately in relation to the amount of opioid that's available. Another point I want to make here is this issue about privileging the Western view. I think this map has been done in a particular way. We could have inverted the statistic. You know, we could have America looking very small and all the countries of low use looking very big. And I think that would just make us think slightly differently about things. So I think that's a thing that could be done. And I'll come back to this paper a little bit later on. So these issues that I brought up made me think a little bit more broadly about what research I wanted to do. As I said, mine was in medicine and social science, so anthropology was my background of training. And I wanted to look a little bit more critically at how we practice medicine. I wanted very specifically to look at a non-high-income country. So I went to India to do my research. I appreciate I'm still from a high-income country, but nonetheless, I wanted to research in that region. And I wanted to make sure that I was looking at all types of pain clinicians. So I wanted to look at practice, both looking at acute pain, chronic pain, and palliative care. So I took interviews and questionnaires from conference attendees from organizations like this, in pain management and in palliative care over several years in India, in different regions, and visited lots of people in their workplaces. So I won't spend a lot of time on all of the detail of it, but I just want to highlight one really important point from the research. And this might sound really obvious on one level, but there was a complete consensus that pain is a medical problem that needs treating, perhaps not surprisingly, talking to pain physicians. And they also talked about the need that we often have to persuade other people that that's a problem. And I thought that was quite interesting if we start really thinking about what that's telling us. So we're saying pain is a medical problem, it's a problem to be fixed. And that sounds to us completely counterintuitive, completely obvious. We're doctors, we're pain doctors, and we have a desire to relieve people's suffering, and often we're very good at it. We're good at it when we think about acute pain, and usually very good at it with treating pain at the end of life. But when we start to think a little bit more critically, and it's difficult, I think, thinking very critically about this work, because, you know, we're scientists, we all went to medical school, we were good at maths and science at school, that's why we got in. And really challenging that from a philosophical point of view can be a little bit tricky. I know I found it difficult, but I think it is an important thing to try to do. Pain has been around an awful lot longer than we have as pain physicians, and it's been around a lot longer than Western medicine has, and it's been around longer than, from an evolutionary perspective, from before humans have been around. Opium's also been around for many thousands of years. This is not a new problem that we are encountering. So this man-made model, this idea of medicine and how we can fix things, it is good. It's really good for lots of things. It's really good for acute pain. It's good for pain at the end of life. Good for loads of other things within medicine. But it's not good for everything. And I think it's not a perfect fit for example, chronic non-cancer pain. When we think of chronic non-cancer pain, we can help people to manage their pain, but we can't cure it in the way that we would perhaps like to, or the way that we can with other conditions. So it's what we'd say in the UK, it's a square peg being fitted into a round hole, and there's problems around the edges. I just want to demonstrate that again by going back to the paper I mentioned, the Lancet report with the map, with the distorted land sizes. And they are talking about access to palliative care. And they talk about this concept of people who need palliative care as being people with a thing they call serious health-related suffering. And it sounds really sensible when we first start talking about it. So they talk about the fact that we should be helping all health conditions associated with the end of life, which, you know, it makes sense that we should be treating maybe respiratory conditions as well as cancer if people are coming to the end of their life. That makes sense. They say we should be talking about chronic or acute life-threatening or life-limiting health conditions, diseases, and injuries. That also sounds sensible, I think. But then I think it starts to get a bit more complicated, because they say they explicitly reject any time or prognostic limitation on access. And they take it further. They also say they decide not to focus on acute and chronic health conditions that are not life-threatening or life-limiting, including chronic non-malignant pain. And that's where I start to find it a bit more difficult, because I find it tricky to see a clear dividing line between these. I'm not saying that there aren't extremes that we can put people in, but I think there is some grey area in the middle, and I think it's very important to acknowledge that and remember that things are not clear-cut. These are slightly artificial categories that we are putting in place, and there's very good reasons why we're doing that, but they aren't a perfect fit. So there's then some potential problems, I think. As I said, something like chronic non-cancer pain is not a problem that can be medically fixed. And many of us have talked this morning about the need for a biopsychosocial, or as someone I think very sensibly said, the you know what I mean, the socio-psycho-bio model, turning things around, because it isn't, the biological aspect of it is really quite a small element of it. And the other point I want to make in relation to pain is that palliative care is changing its remit. And I think that, although it's contested and it's not clear-cut and not everybody wants to increase its remit, there is in some circles a move to do that, and certainly on the global stage. And I think this has implications for opioid use when we come back to the point Sarah was making at the beginning. If we look at addressing the opioid crisis of either high use or underuse, if we do that in isolation, I think we have a problem. I think we need to address them together, and we need to embrace that middle ground, that grey area that we're perhaps not so comfortable in. So in conclusion, the medical models that we use, although they're very useful in some circumstances, have limitations that we don't frequently acknowledge. And I think the additional problem with this is that if we try to treat absolutely everything that doesn't fit well into the model, we have fewer resources to use from where it is a really good use. So we need to be targeting where we use the medical models. It's particularly relevant, I think, when we're considering the skewed view that we often get when we hear about things. We often hear of the view, privileging the view of high-income countries. The global picture of access to pain management is hugely variable, so if we privilege one view, we're going to be in trouble. Most of the initiatives, some of the big global initiatives, come from palliative care, and therefore they're only looking at opioid use. And as we know, there are way more treatments that we need to think of when we're looking at pain management. So we need to consider all of these improvements and initiatives in a wider global context and work together. Thank you.
Any questions?
Professor Durrani from DG all types of pains are worsened by excitation of excitable tissue. I think we should consider a neurotransmitter which suppresses excitation of all excitable tissue, nervous system, peripheral nervous systems, muscles, bronchial smooth muscles, cardiac cells, and cardiac conduction cells. I mean magnesium used in eclampsia, status epilepticus, tetanus, bronchospasm, severe spasm, as well as cardiac arrhythmias. What are the concerns of this learning form?
Any comments from the audience? Use of magnesium for the relief of pain?
Actually, Professor Durrani, you're right in your point of view. Magnesium has been used for the treatment of some kind of chronic pains. We have a very little experience of using in our centers magnesium for chronic pains or whatsoever the pain that is not, controllable. Sometimes you do interventions, patients came to you after having a lot of interventions, 3 or 4 from different pain physicians. So you need to channelize that patient. You need to give him a alternative way. So this session was specifically dedicated to the novel pain medicines. all the medicines have been discussed, they are all the alternative to the interventions as well. Once you are stuck in a patient, to treat a patient of a pain is a very difficult thing, you know. We have a lot of experienced people over here. They have experience of 30 odd years, 20 odd years, and many of seniors of us. But you know, we got referrals of patients treated from different pain physicians as well. So as a whole, pain medicine is not just putting a needle and giving a pain relief for a short term or anything like that. So all these novel drugs, use of CBDs, use of ketamine and opioids as well, and there are other drugs as well, magnesium bisphosphonates, even lignocaine as well. We are using in our clinics frequently, and they are putting good results as well. So I think we can think beyond the box, and we can use these novel pain medicines as well in our practice. I hope we have answered your question.
Let me add one thing. Magnesium basically is a smooth muscle relaxant. I don't think it has got any analgesic properties. We have been trying to use it in infusions with different painful condition, but without any desirable effects. Yes, of course, it is good in eclampsia, it is good in asthmatic patient, it decreases the blood pressure, it can cause relaxation of the smooth muscle. As a pain management drug, I don't think so. It has got any role. Anybody can comment? Tetanus, again, it relaxes the muscle. It relaxes the muscle, and by virtue of relaxation of the muscle, it improves the pain. Cause of the pain is the spasm. It relieves the spasm, and that's why it gives good relief. But any comments from audience?
Ji. My question is to Dr. Gauhar. Ketamine is very good drug we are using at our center, but mixed with dexmedetomidine. If we mix the ketamine with dexmed, it gives very good results. Your comments?
So thank you very much, Dr. Khalid. I did not want to deliberately touch the dexmedetomidine and midazolam because a lot of literature available that if the ketamine you are giving a plant ketamine, then and you're monitoring that, then you have to have a midazolam or dexmedetomidine. But simultaneously giving, there's no evidence as such. But having a backup plan, that if patient has some kind of a restlessness or impaired sleep, or at that moment of time the hallucination, I think that is yes available. And because in our own center there is a variation of practices, so some of the faculty prefer in our setup prefer dexmedetomidine in ketamine infusion cases.
Thank you very much, Dr. Gauhar, and we'll take just one more question and then we'll move.
So Mujib Baloch from the UK. It's just to shed my own insights into magnesium that you very rightly actually asked about, because it does have an effect on pain. We know it has an effect on pain through calcium channel interactions. The problem has been, certainly in my experience and those that have researched it, that although in theory it should be very, very effective, in practice it doesn't seem to work. And I've used it, for example, as an alternative to guanethidine, in guanethidine blockade. We've used it as infusions. If you look at the literature in peripheral neuropathic pain, for example, in chemotherapy-induced peripheral neuropathic pain, it doesn't work. So theoretically great, practice doesn't. And in fact, in those that we've used it as an alternative to guanethidine, we did a short series, it actually worsened the pain, especially immediately post. It flared things up. So that I thought was useful just to share my own insights.
Thank you very much, sir. Now I'll request our chairpersons to kindly share their concluding remarks.
Thank you very much. All these 3 lectures were excellent, and we are thankful to this Dr. Michael Graham, Dr. Gauhar Afshan, and Dr. Clare for educating us about this cannabis, ketamine, and opioids. One of the slides of Dr. Clare mentioned that this human being has a very long association with the pain. I think pain and human being, they are very long. Since the birth of human being, pain was there. And seeking response, seeking relief from this pain has always been a natural response. And different era, people have been using these cannabis as well. They have been using morphines. They have been using so many drugs. And this fight against pain is still on. And still we are fighting to overcome these pain problems by using different problems. Thank you very much. Yes.
Thank you very much again, and all the three speakers have spoke elaborated talks on all the topics regarding CBD, strict regulation. One slide I saw in Dr. Mike's presentation. For the audience, that Pakistan hemp policy has been approved already, and Drug Regulatory Authority of Pakistan is already working on that. And hopefully in next few months or year or so, there will be authority who will be monitoring CBD policies as well. And thank you once again. Thank you. Thank you all for the audience.
Thank
for
you very
patient
much,
listening.
sir, and thank you very much. The lunch is now ready to be served. So we'll be meeting here again at 2:20 p.m. sharp. And besides this session, one session will be conducted in this hall. That will be the oral presentations, and the poster presentations, they will be conducted in the hallway. So we'll be conducting 3 sessions after 2:20 p.m. Thank you so much.